Okay, let's get started. Good evening to all of you. Welcome to the ACCP Grand Rounds. Today, I will be your host. My name is Dr. Susan Rashid. Today, we have the honor and the pleasure to learn about suicide in jails and prisons. And this is a very important topic in correctional health care. We are going to have our speaker present this topic today. His name is Dr. Anasari Daniel. He is a forensic psychiatrist with decades of experience in mental health and correctional psychiatry. He has worked with mentally ill and suicidal incarcerated patients. In doing so, he has also collaborated with correctional officers and other professionals. He was a mental health and correctional administrator, having worked as the director of psychiatric services for the Missouri Department of Corrections between the years of 2000 to 2007. For several years, he provided direct psychiatric services in the county jail and various prisons throughout the state of Missouri. In addition, he has also analyzed approximately 130 incarcerated patients who unfortunately committed suicide. He has published his research on suicide in the correctional setting in peer-reviewed professional journals. He has testified as an expert witness in federal and state courts, where suicide has led to lawsuits. Along with 7 distinguished researchers and clinicians from the United States, Canada, and Europe, he has been a part of updating the resource guide on suicide prevention in jails for the World Health Organization in 2006. Dr. Daniel is the author of Suicide in Jails and Prisons, Preventative and Legal Perspectives. Here's look at the book. It is available on Amazon.com and in your local bookstores. He is passionate about suicide prevention and advancing healthcare for people who are incarcerated so that all stakeholders have the safest and healthiest outcomes possible. Through his research studies and practice, Dr. Daniel established himself as an expert on suicide in jails and prisons. When I saw this book on Amazon, I got it right away last year. So I was very, very excited that he's going to be doing this presentation for us today. And he is very much sought after by expert consultants and witnesses in suicide-related lawsuits. He has also provided expert consultations to attorneys in 75 suicide-related litigations across the United States and testified by depositions and in jury trials. Without further ado, I present to you Dr. Daniel, and I'm going to go ahead and share the screen. And we're going to get started with his presentation today. And please, he's going to do his presentation, everyone, and we can have the questions at the very end of this presentation, and he'll be delighted to answer those. I hand the stage over to you, Dr. Daniel.
Thank you, Susan. And thank you, Mike Perini, Dr. Perini, and American College of Correctional Physicians, who gave me this opportunity to talk about my favorite subject, suicide in jails and prisons. Before we start, Dr. Perini wanted me to talk a little bit about forensic psychiatry. What is forensic psychiatry? It is that branch of medicine. Psychiatry intersects with the law. It utilizes the psychological principles in order to provide assessment and treatment of those people who come before the courts of law. It's basically 2 major areas, criminal and civil. Criminal area addresses competency to stand trial, evaluation of the defendant for insanity defense and subsequent testimony if needed, and also involves people who are petitioning for a release from the Department of Mental Health after having been committed there on NGRI, not guilty by reason of insanity. The civil side involves evaluation of the claimants for workers' compensation, personal injury, when there is an issue of testamentary capacity, issue of guardianship, and all of those areas. In addition to these 2 major domains, we have correctional psychiatry. I see in the audience Dr. Metzner, who has been in the forefront of developing correctional psychiatry as a discipline, as a major branch of forensic psychiatry. And we are addressing there the evaluation of inmates who have mental illness and providing treatment in order to reduce recidivism and back to adjustment back to society. Then finally, there is a sub area called expert witnessing, which I'm very much part of it. And of course, expert witnessing have improved substantially during the last few years, ever since Supreme Court has addressed that issue through Daubert versus Merrell Pharmaceuticals and subsequent couple of cases. There, the reliability and credibility of expert witnessing has been addressed based upon the reliable methodology an expert witness is using. Significant developments have occurred in forensic psychiatry in the area of using psychological testing to provide objective data for evaluation of the defendants or claimants, I suppose. And neuroscience has been utilized recently, particularly by MRI and PET scan. And during the last few years, especially digital forensics have become a major issue, major development in which alleged perpetrators of sex offenses can be traced. These are the major developments in forensic psychiatry. Let me move on to my topic, that is suicide in jails and prisons. Susan. Next slide. Next slide. What is suicide? It is an intentional act of self-destruction which begins with ideation and includes a plan, means, attempt, and completion. Not all inmates or detainees who have suicidal ideation end up killing themselves. In fact, a small portion of them do. What is more important as from our perspective is a suicide attempt. There are, of course, manipulative suicide attempt and, of course, suicide attempt with near lethal intent. And that is more significant for our purposes. Objectives of this talk include how to prevent suicide, how to save lives, avoid lawsuits, and save millions of dollars. As part of this presentation, I'll be talking about the role of correctional physicians in the forefront of preventing suicide. So throughout my presentation, I'll be addressing their role, specifically vis-a-vis in a relation with other professionals. Susan? Okay. Through Google Scholar, I have collected newspaper clippings or articles during the last 2 years from around the world. And this is a service you all can utilize. If you have a favorite subject, put that on Google Scholar, and you will be bombarded with information from Google Scholar in your inbox. So this way I have collected newspaper articles during the last 2 years. And I was alarmed at the fact that the suicide rate has been substantially increasing worldwide, particularly so in the United States. In November 2022, there was a major news articles in New York Times. The headline was, "Jail is the death sentence for a growing number of Americans." That's concerning all kinds of deaths in jails. And if you look at this particular slide, I have highlighted some of the important points. It shows these articles highlight phrases like drawn criticism, rising number, apparent suicide, historic high, leading cause of death, and 18 in custody deaths in 2022 were too many. That is concerning Alaska. So this happens in every state. So for sure, none of us want to be highlighted or broadcast this way. So let's do what we can do in our own jail. Next. Incarceration by numbers. United States has the highest incarceration rate or number of people behind bars. It is about 2.2 to 2 million people annually. And this number has been stable for the last several years. If you consider the incarceration per race, Blacks represent 938 per 100,000, American Indian 778, Hispanics 446 per 100,000, and whites 183. So if you look at this graph or this slide, you can see the white is only 1/5 of the Black population in jails and prisons, as we all know. So for many Blacks, Indigenous, and Latinos, the experience of incarceration is a major social determinant of health. That we share that concern, and we already are fully aware of that. Next slide. Just one before. Okay, all right. Susan, one slide before.
Yes, I know it's not, for whatever reason, it's not letting me. My apologies. Hold on a second. You want to go to this slide, right? Yes.
Yes, that's correct, because that is important.
My apologies. It's being a little difficult. It's this one, right?
Yes, that's correct.
Okay.
After Sandra Bland's death in Texas, Waller County, Texas in 2015, Huffington Post have hired a group of researchers and investigators. They wanted to collect data on every death in all US prisons. They collected the data for 1 full year, and they utilized various techniques, which I don't have time to go into that, but they found that 815 people died in US prisons between June 2015 and June 2016. And it's important to note that 182 deaths occurred in the first 3 days. An additional 121 deaths occurred in the next 3 to 7 days. So total number of deaths in the first 7 days is 303. So this period is highly significant for those of us who work in jails, particularly in jails, in prison as well, but this is more crucial for the jails population. And they collected the data on the number of people who committed suicide. Out of these 815, 270 killed themselves. That represents about 33%. An interesting finding was that suicide dropped dramatically after 7 days. So that's a significant point. Let's move on. Next slide. Few other quick statistics. 60% of the individuals with a history of mental illness in our system do not receive adequate mental health care. More than 75% of the jail inmates who died by suicide from 2000 to 2019 were evading adjudication, or they were pre-trial detainees. So that's a significant finding. And during the period between 2000 to 2019, an average of 320 died by suicide. If you look carefully at the Bureau of Justice Statistics, they notice about, they report about 355 per year. there is an uptrend between from 2015 to 2019 with regard to number of suicide. We do not know specifically why this has occurred, but this is probably not due to COVID, but we do not have statistics 2021, although I hear anecdotal stories that the number of jails reporting increasing number of suicide in a particular jail. It may be due to COVID isolation and other related psychological factors. One important point that I wanted to point out is the last sentence. 90% of the suicide, this is a study from Scotland. Sheriffs ruled nothing could have been done to prevent or to foresee or to prevent prisoner death. That's a prevailing attitude even in our country. Many sheriffs report that, he is going to commit suicide. We cannot do much about it. Next slide. So what is the scope of the problem? Suicide is a major public health issue in the United States and worldwide. It is the #1 cause of death in jails and 3rd cause in prisons. Next. In general, what are the vulnerable categories for suicide? They are young males, elderly men, indigenous people, persons with mental illness, persons with alcohol or substance abuse, persons who previously attempted suicide, and persons in custody. The take-home point here is that all of these factors play a significant role in the causation and contribution of suicide. Persons in custody is one of the highest risk groups. Another risk group, of course, we all know, are soldiers and veterans. They have a higher suicide rate. But as far as we are concerned, persons in custody have a higher suicide risk. Next. Now, there's a couple of statistics that I wanted to report. In 1999, in the United States, overall, 29,000 people killed themselves. In 2019, the number is 45,173. It's not in the slide, but I am speaking from my understanding of the issue. In 2020, the number has jumped to 46,900, keeping the population as a steady denominator. So suicide has been increasing substantially over these years. Scope of the problem. In the general public, historically, that is, when I say historically, before, when I use the term historically, as it applies to jails and prisons, it applies to the period before 2000. So it was about 12 per 100,000 the general public, and currently it's almost same, 12. It hasn't changed much. But in jails, due to the implementation of suicide prevention program, establishment of adequate or nearly or adequate mental health service delivery system, the number of suicides have decreased in jails from a high of 52 to 129 before 2000 per 100,000 to 46. In state prisons, it has decreased from 24 to 40 to 17, and in federal prisons, it is currently 10. With regard to the method, which I'll come a little bit later, 90% of the suicide occur by hanging. Next slide. Cost of litigation. Close to 67% of the civil lawsuits were settled out of court, according to a study from Cornell School of Law. They have studied the collected data on civil lawsuits in 1990s and forward, but the Department of Justice gives a different data. According to the Department of Justice, 97% of the civil lawsuits are settled out of court. We do not know why the two data are significantly different, but be that it may, most of the civil lawsuits are settled out of court. Millions are paid out per settlement. While the precise amounts of out-of-court settlements are not available known, a 2004 U.S. Department of Justice report mentioned that plaintiffs won 55% of the court actions with $4.4 billion US. This is taking into consideration all lawsuits, not specifically related to jails and prisons. Let me report my experience. As Susan has said, I have participated as an expert consultant in over 100 lawsuits, jail and prison lawsuits, out of which 75 were related to suicide. 85% of these cases were settled out of court, and 3 cases were dismissed outright. 7 or 8 cases went to what is known as summary judgment. And out of those summary judgment, 3 or 4 were denied. When I say denied, when it applies to jails and prisons, when they petition for a summary judgment. When the summary judgment were denied, all of the cases that I was involved proceed to settlement. And the amount of settlement that I'm personally aware of ranged from $300,000 per case to $5 million. The case which settled for $5 million involved a key factor. In that case, the correctional officers clearly falsified the suicide log sheet. So falsification draws a higher amount of settlement. That is my personal experience. Next, move on. Next slide. Next, this is a case that I'm going to present. Since it is a grand rounds, let me find the case. I have not put it out on the online because of specific reasons. The case I'm going to talk about is a real life case. If any one of you recognize this case, I have tried to alter some of the basic things in order not to identify, but this is an important, this case, I am presenting this case to highlight the role of correctional physicians in suicide prevention. This is a case involving a high-profile detainee. He was 55 years old. He committed suicide in an urban jail where 98% of the inmates were Blacks and Hispanics. They ranged in age between 20 and 35. He slit his jugular vein with a razor blade supplied by the jail, and he died by exsanguination. This detainee has sexually assaulted a woman whom he knew for 2 decades. Later, he was charged with a second-degree sexual assault. On the day of the assault, he told the victim that he would go home and shoot himself. And this gentleman had no history of sex offenses in the past. After the sexual assault, he went home and he drank to excess and took Tylenol and barbiturate and went to sleep. His wife could not wake him up the next morning. He was totally unresponsive. 911 was called. He was taken to the local hospital where he was deemed, he was, of course, given appropriate medical care. When he woke up, he was deemed depressed and suicidal. Interestingly, his wife told the medical staff that he could be suicidal. After he became stable, he was arrested in the hospital and taken to local jail. In the hospital, he was prescribed an antidepressant. And at the jail, he was processed as a new intake. The jail physician, which is somewhat unusual, is the person who performed intake screening. He used a screening questionnaire available on a computer program where the decedent answered with a no to all questions. Recognizing that he was a first-time detainee, the physician referred him to mental health. But the physician did not explore further the questions answered with a no, and he did not inquire about his immediate past medical history of hospitalization, and about the circumstances of his arrest or the nature of the charge. In fact, the physician took his no at face value. However, the physician knew that he was recently hospitalized. No attempts were made to obtain the medical records from that hospital, and his medication was not renewed. So a couple of key points here that we tend to take no from inmates who are probably thinking about suicide. No is a common answer to screening questionnaire. What is important here is to explore further the basis of no and try to get information from previous hospitalization, previous suicide attempt, and clearly this gentleman attempted suicide by overdosing or taking too much alcohol and consuming Tylenol and barbiturates. Furthermore, his medication was not renewed. Next slide. I approach suicide prevention from basically two vantage points. I've written about the collaborative responsibility of all actors, all professionals within our system. The correctional staff, of course, they have to maintain safety and security of the unit. They observe the behavioral and emotional changes of the inmate. They are, in fact, the eyes and ears of suicide prevention. They, of course, take the inmates or detainees for medical appointments, etc. The mental health staff, furthermore, the correctional staff, if someone is placed on suicide watch, they maintain suicide watch at varying intervals on a staggered basis, and they make appropriate logging. The mental health staff provides mental health evaluation, suicide risk assessment, and individual therapy, group therapy if that is possible. The psychiatrists provide the psychiatric evaluation and medication management. The medical staff, of course, are involved in medical diagnosis, physical examination, conducting chronic care clinics, and communicating their evaluation and diagnosis to various other professionals, either in electronic form or through records. The nursing staff, of course, are responsible for medication dispensation and documentation through MAR. And they also make observations of the emotional and behavioral changes whenever possible So we and the administration provides the structure and organization of the jail and or prison. But more importantly, from a suicide prevention point of view, it is important for the administration to create an attitude among the staff that suicide is preventable or can be prevented. So all of these players have to work, have their own unique role, but they have to work together. So only when these professionals work together, we can approach the issue of suicide prevention. I also approach from a legal liability standpoint, based upon case law and the lawsuits from case law from the various lawsuits. Since 1980, during the last 40 years, we have collected a substantial amount of data from various court decisions, what prompts them to decide the liability part of these cases, and of course since Estelle versus Gamble, Ruiz versus Estelle cases, the courts have established that prisoners have a right to receive treatment for their medical and mental health, which of course was established subsequent case decisions. And NCCHC have established certain guidelines for the delivery of mental health services, and also the requirement of suicide prevention, suicide prevention, suicide training program, etc. So I approach suicide prevention. If we have paid attention to what are the factors, what is the basis of these liability decisions by court, we can implement a better suicide prevention program that addresses the evaluation or screening and evaluation of the at-risk individuals, monitoring them, and providing treatment. Next slide. I have identified several key challenges in suicide prevention that I have written in my book, and here I'm going to talk about four or five major issues. Communication is a major issue. The screening sometimes is done by trained correctional professionals, correctional officers, or mental health professionals. They enter the data on the computer unless there is a suicide alert, and the alert is looked into by the subsequent evaluators like mental health professional or psychiatrists. That's the dead information there. So that communication is a major issue. Communication also sometimes fails. Communication fails between mental health, medical staff, and correctional officers, nursing staff, physicians, and psychiatrists, and family members and jail staff, and between inmates and officers, and all kinds of communication problems. So the key to address this issue is proper documentation and review of the documentation to address the potential at-risk individuals and providing treatment. Next is screening. Adequacy of screening instrument and implementation has been a major issue in various jails, probably in many jails in the United States. And in fact, failure of screening, in many cases I have been involved, has been a major issue which leads to further court action. Sometimes the adequacy of screening instrument is an issue. Sometimes whenever there is a screening instrument, proper implementation is an issue. And I have come across a situation in which one particular officer brought in about 10, 15 inmates at booking, and he yelled out to them, "Are you all, is anybody suicidal here?" And everybody said no. So in all those 10 files, he denied suicidal ideation. The fact remains, some of them might be, who knows? So why do we screen? We screen, basically, screening leads to further mental health evaluation and psychiatric evaluation. Screening also identifies individuals who are at risk, who may present with suicidal ideation, and they can be placed on suicide watch, either constant watch, 15-minute watch, or 30-minute watch on a staggered level, depending upon the severity and intensity of suicidal ideation. Then also it paves or it drives treatment. And screening, proper screening is a legal, proper screening and documentation can be basis of an appropriate legal defense. Next. Delay in psychiatric care. This is another important point I have come across time and again. And in one case out of Pennsylvania, scheduling appointment was an issue. And clearly this dissident had a long-standing history of psychiatric illness, and he came with that information, but scheduling was delayed for approximately 2 weeks. And that was a major issue in that case. Renewing prescription. This is usually done by the physician on call, who could be a general physician or a psychiatrist. Renewing the prescription is an important issue. We do not have to renew exactly the same medication, but the medication can be of the same category. If there is a concern about budgeting, then of course we can replace with less expensive medication, but address the same clinical issue. We can do that. Another issue, not bridging medication when inmates enter the jail or prison. This is a major issue. Sometimes in one case, in one case I was involved in out of Wisconsin, the physician absolutely refused to bridge the medication because he wanted to have the psychiatrist come in, and that particular jail had only 2 half-days of psychiatric coverage. So I think it is important, based upon my experience and literature review, I feel that bridging medication is important. Next is lack of treatment of substance withdrawal. This is a major concern. When in doubt, I would advise, based upon my experience and various review of various cases, I would advise that physicians may place inmates who come into the system with substance intoxication on substance withdrawal protocol. Alcohol withdrawal 1 to 3 to 4 days, and opiate withdrawal up to 7 days, and benzodiazepine withdrawal up to 14 days. So when I talked about the timing of death, this is a crucial piece of information for medical providers to place the inmate who come into the system, any sort of withdrawal, alcohol, opiate, or mixed withdrawal, to place that individual on withdrawal protocol. So that's important. The final issue is lack of training. Training is a substantially significant aspect of suicide prevention, and we address that issue for correctional officers, mental health professionals, and correctional physicians and psychiatrists. It is my view, even though is my view, all of the individuals, even though our disciplines may be involved in getting enough continuing medical education, suicide prevention as a particular of particular importance. So we must participate in training that will keep our knowledge active and be very careful about evaluating individuals. Okay. Now, I wanted to talk about next few slides. I'm talking about suicidal inmate profile as important here. You can move on to the next slide. Next slide. Okay. The next few slides, I'm addressing the risk factors which can be divided into demographic, then psychological or psychiatric risk factors, and institutional risk factors. For the sake of time, I'm going to talk in general terms and highlighting the importance of various pieces of information. The risk factors can be divided into two groups. One is the stable risk factors. The second is dynamic risk factors. Stable risk factors are non-variable factors such as age, race, type of crime they came with, history of past psychiatric treatment, medication treatment, history of prior suicide attempt. By the way, prior near lethal suicide attempt is the most significant predictor of suicide in jails and prisons. This piece of information, anytime we fail to collect that piece of information, we are opening ourselves for legal liability if the individual ends up killing themselves. So that is important to collect. It is not only the responsibility of mental health professionals, but also physicians and psychiatrists to gather that information. So the stable risk factors are non-variable risk factors. Then we have dynamic risk factors, which are basically anything which is new happening when the detainee is in our system, such as loss of a loved one, undergoing divorce, custody situation, not able to see their children, a new sentence, a harsh sentence, or an unexpected sentence, or denial of probation, parole, denial of parole, not probation, denial of parole, any untoward event which happens while the detainee or the inmate in the system. Not all people with risk factors, stable risk factors, end up killing themselves. Not all people who have dynamic risk factors end up killing themselves. What is important is the interplay between the stable risk factors and dynamic risk factors. When the individual, for example, I have had several cases in which the inmate end up killing themselves after a undesirable court proceedings. By the way, in the case that I have described, that there was a discussion in the court about placing that individual in a mental health unit. However, there was only a discussion, no further action has happened. So that's an important point. So when these two factors interact, the dynamic risk factor acts as a precipitant of suicide. We all know that suicidal ideation and suicidal thoughts, intent are transient. I know it is very difficult to capture the suicide intent at the time when it occurs, but how to prevent an undesirable ending is be cognizant of the dynamic risk factors. For example, an undesirable court proceeding. So it is possible that the professionals who are involved in the care of this inmate can take appropriate action and meet with that individual, discuss the matter, and try to provide some intervention there. If necessary, place him on suicide watch as well. So that is important. Another important point in a dynamic, as a dynamic factor that I have come across in my experience is the transfer. A transfer between the institutions. That is especially in prisons, the inmates become familiar with their environment in one particular jail or correctional center. When they are transferred, they could be fish out of water, especially new inmates. So that is an important dynamic precipitant or a factor. Sometimes in these situations, the documentation may not follow the transferred inmate. Although nowadays most of the prisons have electronic system, electronic medical records, so that piece of information is clearly available. So it is the responsibility of physicians and psychiatrists look into the prior medication history and provide a appropriate transition into the new system, into the new location. Another important point is jail to, from the community to jail. That is an important, which I have talked about before. So the interplay is very important. So let's move on to the next slide. Next one. This one. I want to address the issue of what is the most important mental state of a suicidal individual. You can have any number of psychiatric disorders, psychotic disorders, major depressive disorder, anxiety disorder. But what I'm more concerned about is the mental state of the individual. This, I can describe it this way: detainees who are anxious, agitated, and express feelings of hopelessness. If those three things occur, along with the history of depression, then that is an important aspect. Then if that individual is a highly impulsive individual, that increases the risk of suicide. So what we have to observe is the change in change in the mental state. We all know that the usual observations we made is the inmates give away their possessions. They tend to isolate themselves. They refuse to eat. They refuse to take showers, and they may refuse to go to recreation. These are things to be noticed by correctional staff, and sometimes it may come to the attention of physicians and psychiatrists, but these are behavioral observations. If those observations or changes occur in an extremely agitated, anxious individual who express feelings of hopelessness and they find themselves no way out, that is the time that we have to be concerned about. Next slide, please. I just want to say a word about administrative segregation. Administrative segregation is a is an important risk factor, mainly because the individual or the detainee spends, as we all know, 22 to 23 hours in isolation, and that can precipitate.
Hi, I'm sorry to interrupt. I was just informed that we are at the very end of the hour of this session, and there are audience members that would like to ask questions. So that we can just maybe wrap it up in a little bit so we can also address questions from the audience.
Yes, okay. there are a lot more to discuss, so I'm going to stop here and let's field the questions.
All right, great. Sorry about that. I was just informed. Let's see here. Does anybody want to unmute and ask questions? Feel free to do so, or just raise your hand and we can get you. Dr. Staples-Horn, hi, nice to see you.
Hi. Thank you for the presentation, Dr. Daniel. I have a question with regards to the environment in which the inmates or youth may be housed. I know we do a lot of breakaway fire extinguishers, things like that. Have you had very many cases where the environment was involved or implicated in the suicide and was found at fault with regards to the person being able to successfully complete suicide?
Yes, housing has been an issue in a couple of cases I was involved in. The administrative segregation, of course, is one part, but overcrowding is another issue. In the couple of cases that I was involved in, the overcrowding has not been a major factor in court decision because the system and our courts of law know our real problems in terms of housing issues and overcrowding. I don't think the courts have laid particular emphasis on that part of the litigation. It's mostly on the clinical deviations or clinical failings and failure to do certain things, acts of commission and acts of omission. Those are the basis of successful cases or cases which are settled.
Yeah, I know there are some issues at one of our local jails where it's deteriorating to such an extent that the people are being able to actually pull pieces of the building apart to create weapons and to be able to do self-injury. So I just wondered if any of that had come up before.
Yeah, it has come up in various complaints, but it hasn't progressed to any kind of significant consideration by court.
Thank you.
Dr. Daniel, this is Jeff Metzner. Good evening.
Hi, Dr. Metzner. How are you?
I'm good, thank you. Would you comment on your thoughts about whether clinicians, mental health clinicians who do suicide risk assessments need to be credentialed for that, or whether your experience is that most mental health clinicians know how to do adequate SREs?
Yes, the short answer is yes. I have a case which was settled for a high amount. In such a case where mental health clinician was not trained properly, they did this particular individual performed what is known as a crisis assessment, and he did not go through appropriate training. My position is that anyone who does suicide risk assessment has to be at least master's level, properly credentialed and trained.
Thank you.
Dr. Daniel, on slide 16, you had said one of the risk factors that you found in a suicidal activities in the correctional setting was that bridging, that taking that time to bridge between psychiatric medications and starting it, because psychiatrists sometimes come like maybe twice a week. And so the primary care doctor doesn't start it because they wait for the psychiatry, but that can be a risk factor. As a primary care physician myself, I feel kind of hesitant to start psychiatric medications on patients who have severe mental health illness. So what do you say to that for primary care physicians? Should we just start mood stabilizers and antipsychotics, even though it may not be the appropriate psychiatric regimen? It's kind of like a catch-22. So I just wanted to hear your perspective.
My position is that, Susan, of course, we have to do a clinical history taking, what sort of medication the individual has been taking. And there are medications which we general physicians must use or can use to address anxiety, depression, which are safe medication during the interim period, which the medications are closely similar to what he has been or she has been taking. So that's my position. At least it will decrease the liability factor if you do that. I know that, we do not want to practice outside of our discipline, but we are in the uncomfortable position of, facing potential legal action if something bad happens.
Okay. Dr. Mike, Dr. Pureni, yes, our
Thanks, Susan. I joined in about more than halfway in, I'm afraid, and I'm really grateful to you for offering to fill in, and grateful to you, Dr. Daniel, for being willing to give a presentation. I have a quick question, and then hopefully there are more questions. And my question just has to do with, as a primary care doctor, just trying to take care of somebody. When I see a patient and they're acting a little off and they're in seg, and I know that they've just gotten a big sentence, and I ask them, are they suicidal? And they tell me, oh, no, I'm fine. As a primary care doc, I'm smart enough to know that this guy has multiple risk factors. I guess I tend to either send them to the mental health people if I trusted them, or ask for a suicide watch myself. But it's sticky. It's a difficult situation when they say no, but you know that all the risk factors are there for suicide. And the corollary question has to do with what's, besides my ethical responsibility to this patient, what's my legal responsibility if I just worry about risk factors, but he keeps telling me, no, I'm fine?
Well,
That's a tough question, I know, and thank you for attempting to take it on, because it's a question that comes up, I think, for all of us, where we're looking at people, we're sitting there in the office with them, it's not quite right. They tell us they're doing fine, but they've got all these risk factors that have accumulated. And it's a very common, I think, clinical situation. And once in a while, it really goes south. And that's the issue, I think. So thank you for considering it.
Right. That as Mike, as you have mentioned, it is a sticky situation. But I would err on the side of caution. Basically, if I were you, if I have noticed all those risk factors and he has received this bad news, I would refer him to mental health professional right away. That, of course, relieves some onus of responsibility on your part. You have done what is supposed to have been done. You refer the person to mental health professional. If you feel strongly, even though he has denied suicidal ideation, if you feel strongly, I would go ahead and put him under suicide watch. And suicide watch in that situation, that will drive the mental health professional to come and evaluate him and then take appropriate action. So I would do that.
Thank you. I think that's what I would do, and I think it's one of those situations that we're faced with. And if anybody else has any experience with that, I'd love you to join in the comment here. But we've also gone over a little bit. But I appreciate your presentation, and I'm thrilled to realize that everything went okay.
Yes.
I realized later, Susan, that I failed to send you the link, and I was on my way home about 20 minutes in thinking, oh my God, I never sent the link. I hope they got it from Brian or somebody, and because I didn't have my phone available to me today. So anyway, thank you. Anybody else?
Yeah, Dr. Daniels, this is Ed Kern. I'm the Director of Psychiatry for the Alabama Department of Corrections, and I had a question for you. Looking at the suicide data going back 5 years in our system, if you ask the question, how many inmates who die by suicide have seen a primary care physician within the past week, the answer is almost 1 in 3, and the same answer for mental health. But if you add them together, really 6 in 10 have seen one or the other. So focusing on primary care for a moment, what would you say would be some of the things that a primary care physician might focus on, especially looking for changes in that inmate? What might be some of the things that would be actionable that would trigger you to say, we need to go the extra mile with this person?
Well, obviously, I would look at not taking the denial at face value, number one. Then I will look at the clinical history. What brought him in? What kind of offense he has been convicted or charged with? Sexual offenses is a big factor there. If he's a high-profile individual, that's a factor. First-time detainee, that's another factor. If he's a young person, yes. And then, of course, I look at the diagnosis part of it: depression, anxiety, clinical mental state of agitation, feelings of hopelessness, withdrawal behaviors, isolation, all of those things. I will look at it. And then basically I would do as a primary care physician, we are all trained at least to do a mental status examination, not in detail, at least to ask questions about, mood, emotional changes, orientation, memory, thought process, thought content, all of those things. I'll do a mental status examination and formulate a diagnosis. Then, of course, physicians are competent to basically address the medical issues. So if that plays into the potential suicidal, ideation or behavior, I will address that issue.
And just quickly, one of the things that I noticed is that a significant number of inmates who present to primary care will describe either difficult to manage pain, not necessarily severe, but persistent, and they get very frustrated with it, or they'll refuse treatment, and it's not of almost any kind. It's not clear why they're refusing. And I just wondered if those kind of things that a primary care physician sees might prompt him to say, why is this inmate not himself, if you will? Why is he becoming frustrated or agitated? That type of thing. Just wondered about your thoughts on that.
Well, as I said, chronic pain is a risk factor, but chronic pain alone is not a risk factor if it is based upon a significant medical issue that we need to address. That can lead to depression, lead to hopelessness and no way out kind of feeling. But I think Mike might be able to shed more light into that part of it than I.
Great. Thank you very much. Excellent.
Hang on a second, everybody. And
Okay.
I've had a request from the audience about saying something or giving a link to your book. And I'm looking at that right now. And so hang on a second, everybody. One thing that, so I don't have an answer to the question besides if a patient tells us they've never done drugs, and you're clear that they have, and patients tell us all the time that, well, they don't always tell us the truth. to be skeptical of, I am not suicidal, because it's exactly the ones who are suicidal who will deny it. And those are the disasters waiting to happen. So I think that that's what I think that's my take home, is that, and that's what, and I heard you saying that, Dr. Daniel, and I appreciate it along the lines of, that's keeping a heavy dose of skepticism about us will help save lives. And we have to go out on a limb once in a while, whether it's calling a mental health professional we trust and saying, hey, can you just put this guy on suicide watch for a couple of days? And because in a lot of facilities, we're not allowed to put them on suicide watch, or, sometimes, there's turf wars, hopefully not in your facility, but it is our responsibility. So anyway.
Can I add something to that? This
I
is
wish you would.
This is Lisa Boweski. I when it comes to the skepticism,
Lisa.
I think we need to go a step further and figure out why they're telling us no when the answer is yes. Is it the way we're asking the question? Is it because they know when they say yes, they're going to get an automatic smock and put into a safety cell? And so they're not lying to us. They just don't want the consequences that might come with that. So I think if we're seeing a lot of people saying no when we think the answer is really yes, it's incumbent upon us to go to the jail administrator or whoever the other folks are and really work with them to see, why are people telling us no? Why aren't they telling us the truth? Because it's usually something, it's often something environmental or other things going on besides just what's within that person.
I agree. Well, we've gone over, and I appreciate you're all being patient with us and going over, and I appreciate your sticking with it, Dr. Daniel. You have something else to say? Go for it, please.
Yes, I have. Let me take 30 seconds, no more than that. The book is available on Amazon.com. But more importantly, I just launched my new website. It's AnnaCyrildaniel.com. And you can get the book from that website, AnnaCyrildaniel.com. And we provide training to correctional officials, officers, mental health professionals. I also launched a new program called Monthly Case Discussion. So if you want to participate in those kind of case discussion, it adds to my knowledge, and I can share whatever knowledge I have. So please go on to that website. Thank you very much for allowing me to participate. Go ahead.
I think we have one more question in the chat room around how well can we depend on a contract for no suicide from a patient that is, and I'll just extrapolate and say from a patient who we see as being having multiple risk factors. So that was a common enough practice in my practice, was to try and contract with a patient for no suicide if I was treating outpatient depression as a primary care doc. Is that a reliable source of information, having a contract with a patient, having a verbal contract with them?
Not at all. I know a famous psychiatrist who is no more, Dr. Simon, Robert Simon, used to write quite a bit about the lack of usefulness of a contract. And so he discouraged using verbal or written contract to as a suicide prevention mechanism, even though many clinicians do use that. But it's the same along the lines of no, I'm not suicidal kind of thing. So only very few people may comply with that kind of thing.